Sir is also Executive Committee member for the South Asian Association of Pediatric Dentistry, Assistant Treasurer for the ISPPD, and has organized multiple CD programs and conferences, including Anukram 2021 and Advanced Clinical Training Workshop. Sir has authored over 90 publications in national and international journals, presented various scientific research papers in national and international conferences, and has been a reviewer for multiple international journals. Sir is the editorial board member for the Asia Pacific Association for Dental and Oral Health and International Journal of Medical and Dental Sciences. Sir is also a fellow of the International College of Dentistry and General Academy of Dental Education. Welcome you, Dr. Deepak, sir.
Thank you very much, sir.
Now I request Dr. Deepak sir to introduce the guest speaker, Dr. Seema Bargale.
Good afternoon, everyone. Afternoon first session speakers is Dr. Seema Bargale, madam. Seema madam finished BDS from VPDCH Sangli, Maharashtra, MDS from Bapuji Dental College and Hospital, Davangere, in healthcare from Sumandeep Vidyapith, Vadodara, and currently, madam, working as a professor in madam's area of interest in pediatric dentistry, especially behavior management of the child, dental trauma, and evidence-based dentistry. Good afternoon, madam.
Thank you all of you for giving this opportunity to me to present one of the toughest topic, that is cleft lip and palate. I would like to thank our President sir, our Secretary sir, and of course our Vice President Madhu sir for giving this opportunity. And I would like to welcome even Dhanu sir and Deepak Bhayya sir, who is going to do the moderation for this session. Over to you, Madhu sir.
Thank you, madam. We'll start the session.
I request Mr. Dev to present the presentation on the screen.
Pre-surgical nasolabial molding. Good afternoon, one and all. Today's my topic is management of children with cleft lip and palate, including pre-surgical nasolabial molding. I, Dr. Seema Bargale, professor at Kemsha Dental College and Hospital, Vadodara, Gujarat. Today I will be covering the topic under this content: definitions, development of palate, development of cleft, classification, etiology, incidence of CLCP, multidisciplinary sequencing, feeding problems and strategies, palatal obturators, pre-surgical nasolabial molding, role of pediatric dentists, and American Cleft Palate Craniofacial Association guidelines. Coming to the definitions, Langman's medical embryology has given definition of cleft lip as due to failure of fusion of the maxillary prominence with the medial nasal prominence. Clinical oriented anatomy by Moore Deliagar has given its to failure of fusion between the medial nasal prominence and maxillary prominence. Cleft palate has described as a result of the nasal septum and or medium palatal processes. In the book of Nelson, textbook of pediatrics, has the cleft lip as a defect in the palate due to failed embryonic fusion. Coming to the development of palate, as already we know about it, primary and privative palate from the frontonasal process, and second palate or palatal process develops from the maxillary process. And when there is any defect or failure, so there will be development of cleft in one of these parameters. Like you can see here, median part of lip and the premaxilla has been detached to give the proper. Coming to the classification, Davis and Ritchie classification based on there are three classifications given by Fogg-Anderson classification, Kearns and Starr classification, American Cleft Palate Association, and graphic methods of recording clefts have been given by Pfeiffer classification, Kernhan's striped Y classification, Miller's modification of striped classification. This is the system of classification of orofacial clefts. In that, we are going to see a few of the classification. One is View's classification, who has given in 1939, where he has described the soft palate cleft and the cleft which is including soft palate and hard palate, cleft including unilateral lip formation and cleft including bilateral formation. Kernhan's Y-strip classification in 1970 has numbered this from right to left, from 1 to 3 for the right side clefts, and for the left side he has given 4, 5, 6, and for the palate and soft palate he has coded 7, 9. Later in Miller modification by Y-strip classification in 1977, he has given the classification which is distributed from nose, then nasal floor, hard palate, and then soft palate with the numbering system. Etiological factors, hereditary factors are the environmental factors like teratogens like rubella virus, thalidomide, then mutant genes, chromosome abbreviations, then increased mineral age, decreased blood supply to nasolateral region, deficiency of any folic acid or vitamin A, and also multifactorial inheritance are there as etiological factors. Next, coming to the incidence of cleft palate and lip. The worldwide incidence of CLPP has been reported to 1 in 600 live births, which is given by Mosley in 2002. International data, which depicts from 2002 to 6, is the average prevalence of cleft lip palate is about 7.94 in 10,000 live births. Countries with the highest and lowest rates were Japan and South Africa respectively. In India, the overall pooled birth prevalence, which is given by Alakpi et al. In 2015, is 1.3 per thousand total births. So estimated that the total number of clefts infants are 50% are affected with combined cleft lip and cleft palate, 30% with isolated cleft palate, and 20% with the isolated cleft lip. Now, when we are talking about the management aspect, it has to go for the multidisciplinary sequence. So there are 4 stages which has been divided for the multidisciplinary approach, which first stage is a maxillary orthopedic stage from birth to 18 months. Stage 2 is primary dentition stage, which from 18 months to 5 years. Stage 3 is late primary or mixed dentition stage from 6 to 11 years. And stage 4 is permanent dentition, which is 12 to 18 years of age. So coming to stage 1, maxillary orthopedic stage, which is from birth to 18 months, where we have to give initial obturative therapy, which will be for the birth to 13 months of the age. Pre-surgical orthopedics, which we have to give like pre-surgical alveolar nasal molding from birth to 5 months of the age. Then we can do the surgical repair at the age of 6 to 10 months. And surgical palatal repair we have to do at 10 to 18 months. Coming to stage 2, that is primary dentition stage, which is from 18 months to 5 years, where we have to take care for post-surgical oral hygiene measures, then restorations of any dental caries if it is present. Then we have to do the adjustments of the obturators to accommodate the erupting primary teeth. And of course, we have to do the follow-up and recall to check for ectopic eruption of these primary teeth in every 3 to 4 months of age. Coming to stage 3, late primary or mixed dentition stage, which is 6 to 11 years, where we have to do a maxillary protraction if in any cases is needed, corrections of the cross bites, then maxillary expansions can be given for the correction of the maxillary retraction cases, and secondary bone graft can be given in few of the cases if it is necessary. Coming to stage 4, which is a permanent dentition stage, which is 12 to 18 years, where orthodontic corrections can be done. Also, the prosthodontic rehabilitation can be done. Lip revision surgery and rhinoplasties also can be done in such cases. Why feeding problems are in CLCP cases? So one is because of the insufficient sucklings and escape of food into the nose. So which reduces the negative intraoral pressure. Then cleft lip leads to poor stabilization of the nipple. Cleft palate reduces area of palatal surface, and tongue position lies, which is too posterior. So to overcome all these things, pigeon bottle has been described by Dr. Brown's natural flow bottle. Even Enfamil cleft palate nursing bottle is available. Mandy Hubbardman feeding bottle is also available. So we can have the different modalities for the feeding strategies, like nasogastric tube also can be used. Syringe feeding also can be done. Spoon feeding is also one of the aspect. Feeding cups. Then you have got a special bottles and nipples, obturator nipples, and feeding plate is also one of the we can give for the patients with cleft lip and palate. So what are the different feeding instructions has to be given? First aspect is position of the posture. So hold the infant in an upright or the semi-sitting position for the feeding. Flow of the liquid, which should avoid continuous flow of liquid. Flow should be slow enough to prevent the choking. Timing should be frequent burping during the feeding has to be given, and burp after 15 to 13 ml of formula can be given here. So liquid viscosity, it should be thickened liquid which creates a slightly more cohesive bolus that moves from slowly through the hypopharynx, allowing more time for its closure. Coming to different palate obturators or the feeding plates. So Chalian in 1971 described an obturator as a disc or plate, natural or artificial, which closes an opening or the defect. So conditions where we can use, before that we have to check for the patient's age, presence of any local avascular conditions in the tissues, and size and extent of the deformity has to be checked. And then we have to give a proper framework for the patient so that it can accommodate by the pediatric dentist. So temporary prosthesis during the period of surgical correction, and when a patient is prone to recurrence of the original lesion that produced the deformity. So what are the different advantages of obturators? It helps to create the sufficient negative pressure that allows of adequate sucking of the milk, reduces the passage of food into the nasopharynx, thus reducing the incidence of otitis media and nasopharyngeal infection, reduces the nasal regurgitation and the incidence of the choking, reduces the potentially painful ulceration of the nasal septum. And what are the different problems which occur with the obturators is frequent visit has to be given by the patient, and repeated constructions has to be done. There may be a fungal growth due to poor oral hygiene. respiratory obstruction and cyanotic episodes while taking impressions. And also, of course, it's a burden of maintenance is there. So coming to pre-surgical nasoalveolar molding appliance, which is first designed by Grayson in 1999 to reshape the alveolar nasal segment prior to the surgical repair. Most of the cleft treatment protocols, the nasal deformity is addressed surgically and requires a number of secondary surgical revision as the affected individual grows to the maturity. So most of the significant advance in surgical left rehabilitation has the pre-surgical nasoalveolar molding with subsequent primary nasal reconstruction. So what is the rationale of this is to reduce the severity of both the hard and soft tissue deformities, facilitating optimal result from the primary surgical correction and enhance outcome of the primary repair. So what is the history behind this? In 1950, McNeil used a series of plates to actively mold the alveolar segments into desired position. This idea was implemented and popularized by the Boston later. In 1975, Georgette and Latham introduced a pin-retained active appliance to simultaneously retract the premaxilla and expand it to the posterior segments. In 1987, Hodge described the use of passive orthopedic plate to show the alignment of the cleft segments. What are the basic principles behind the pre-surgical and alveolar molding appliance? There are two principles basically. One is negative sculpturing and another is passive molding. So in negative sculpturing, it's a serial modification which are made to the internal surface of the molding appliance with the addition or deletion of material in certain areas to get desired shape of alveolus and the nose. In passive molding, custom-made molding plate of the acrylic is used gently to direct the growth of the alveolus to get the desired result later on. So what are the objectives behind the PNAM? Is to decrease the severity of the primary cleft deformity, provide symmetry to the distorted nasal cartilage, non-surgical lengthening of the columella, approximation of the lick segment to decrease the tension in the tissues after the lip repair and thus reducing the scarring. Reduce the need for secondary alveolar bone graft and also to produce additional favorable bone formation by decreasing the size of the cleft and improving nasal tip protection, decreasing the width of the nasal alar base and the nasal tip. The pre-surgical nasoalveolar molding, how does it work on unilateral cleft lip and palate? So in complete unilateral cleft, the nasal floor is absent on the cleft side and the greater alveolar segment is often found to protruding anteriorly, lacking its normal dental arch curvature. So lower lateral cartilage on the cleft side is prolapsed with the deviation of nasal tip and columella towards the non-cleft side. So this NAM can be given to improve the nasal symmetry in complete unilateral cleft and lip, and it can be done till the age of the 9 years. For the bilateral cleft lip and palate, where we can see the premaxilla segment positioned outside the oral cavity with a wide nasal tip and alar base with a severely deficient columella, and the probelium appears to extend directly from the tip of the nose. In this, the objective is to reduce the need for surgical construction of the columella and reduce the number of surgical revisions in complete bilateral cleft lip and palate up to the age of the 8 years. How we are going to take the impression for this intraoral clefts? Molding of the tissue is easier because of the raised level of hyaluronic acid and maternal circulating estrogens in neonates. A small dental instrument like intraoral mirror-like handle can be used for the impression making. Most of the time, elastomeric impression material, mainly the heavy body polysiloxane impression material is being used. Light body is not used because the registration of minute details is not necessary and it may cause the gagging and also tear at the cleft area. It is used while nasal impression taking. Irreversible hydrochloride are never used because of the poor tear strength. Coming to the impression technique, which is given by Grayson and Maul, which we have to do the infant upside down position to prevent aspiration of regurgitated stomach contents. You can see in this slide also the position of the infant. So tray should be placed until the impression material just begin to extrude from the posterior border of the impression where we are taking. So infant should cry while making the impression, which means the airway should be in the patent. So other methods like infant face down position or the infant face up position can also be used in this particular impression technique method. How we are supposed to do the appliance fabrication? So the maxillary impression is poured up with the dental stone with the beading and boxing method and allow it to set. Then undercuts are blocked out of the utility wax and the cast is trimmed properly, leaving the full height of the vestibular intact where the separating medium can be applied. So NAM plate is prepared with either clear self-cure acrylic or the 2 mm thick of sheet of your BioGrano vestibular extension short of 2 mm. Then the NAM molding plate should be polished and it is lined with a thin layer of denture of the soft material. So molding plate is carefully placed in the infant's mouth for the first time, which has to be held in a position with gentle and superiorly directed pressure, where the hole of 5 to 10 mm diameter is created at the height of the palate so that it can provide a proper air passage. Retentive taping. What are the different retentive taping? The primary retention of the appliance is through extraoral facial adhesive tapes, which has to be applied on the cheeks. So broader base tape and a thin suture strip, both we can use it. So broader base tape where we have to use with a 0.5 to 1.5 inches, which has to be added to the cheeks where it has got a barrier between the skin and the retention tape, and it can be remained in the place for a week, and we have to remove by moistening the cheeks. It should allow to rest for 1 to 2 hours. The thin suture strip, which is of 0.25 to 4 inches, can be positioned on the base tapes with the 1/3 of inches of your most of the time which you available is a 3M steady strips which can be used to apply on the cheeks. So orthodontic elastics can be used to provide the better force on the for the retentive taping. Coming to retentive buttons, which is the external retentive button, should be placed at the angle of 30 degrees to occlusal plane. And for unilateral cleft, 1 button, and for the bilateral cleft, 2 buttons are given. It is positioned approximately 40 degrees down from the horizontal to achieve the proper activation, which is given by Grayson and Maul. And the body of the button should be 3 to 5 millimeter wide and can be reduced a little to accommodate the approximation of the lips as the treatment progresses. As you can see in the retention buttons where in the figures which has been given at the angle of 40 degrees. What is exactly biomechanics behind this NAM therapy is one is protrusive alveolar segment that are in a contact with the appliance will actively be retracted by the posteriorly directed force which are delivered by the elastics and tapes. So which is giving a active kind of elastic force. The second active force is generated by the reciprocal additions and the subtraction of hard and soft acrylic tissues that comprise the internal or the tissue facing surface of the molding plate. So this force can be applied from the plate itself. So the molding plate has passive mechanism that contributes to the correction of the alveolar and palatal cleft deformities, which can prevent from the tongue or the nipple or the falciparum from residing on that palatal clefts where separation has to be done. So how does it work is complete unilateral cleft. If you see here, force has been given on this particular area with the retentive button, and in bilateral cleft area, the pressure has to be given. Force is applied with two retentive buttons, as you see in this diagrammatic representation. Now coming to the nasal stent, this is a technique which has been given by the Grayson, which incorporates of the nasal stent, which has been recommended for the alveolar graft, which is decreased to 5 mm. So it is made up of 0.036 gauge round stainless steel wire and resembles as a swan neck or the kidney shape, as you see in this diagram. So it is added to the vestibular shield of the appliance of the nasoalveolar molding appliance. So the tip of the nasal stent is pointed in the direction of the medial wall of the defective nostril, as you see in this picture, and the upper lobe enters the nose, lightly elevates the dome until the reasonable amount of tissue blanching is apparent. So the lower the lobe elevates the nostril apex, and also another technique which is given by Pugora for the NAM technique, where you can see a bend has been given here, like S-shaped bend has been given for the proper holding of your nasal stem. Banham also given the NAM technique, but he has used as an acrylic itself as a nasal stent, where you can appreciate in this photograph, you can see the unilateral nasal stent and bilateral nasal stent. This is a modification given by Banham's. Another modification by Surya and Thompson is given in 2004, where they have given the flexible NAM technique. So what is the time span where we have to use this appliance? So the type of cleft the child has, whether it is unilateral or bilateral, which will determine the amount of time that the child will need to use this NAM. So NAM required average unilateral cleft for 3 months and bilateral cleft around 5 to 6 months. The studies done by Motosuke and Hirosetti et al. 1989, Motosuke and Hirosetti in 1991, they have seen the 3 months use of the appliance for the correction of proper molding of your surgical molding can be achieved. Maul et al. In 1999 and Pai et al. In 2005, the studies they have given 4 months of the usage of appliance to correct the proper nasoalveolar molding. What are the different complications of this nasoalveolar molding? So first is contact dermatitis, and sometimes there will be a mega nostril produced by the improper position of the nasal stent, and pressure from molding plate may cause premature emergence of the labial surface of the maxillary deciduous central incisor, as you see here. The over activation of the nasal stent may produce bruising in the dome area, and overstretching of the columella in a patient with bilateral cleft as a result of the pressure exerted by the prolabium tape and the nasal stent. So next is the segment where we are going to see role of a pediatric dentist. So prenatal and immediate postnatal phase, where parental counseling is very important. So where we have to provide them emotional support to reduce anxiety and guilt. Feeding guidance, of course, demonstrate a proper feeding position, which has to be upright and the semi-upright position. Recommend the specialized cleft feeding bottles or the nipples. Advise on burping and prevention of the aspiration of any milk. So fabrication of feeding obturator has to be done. So in that we can do the pre-surgical orthopedics with the nasoalveolar molding appliance can be given. So fabrication and adjustment to align maxillary segment and improve the nasal symmetry prior to any surgery. Of course, oral hygiene guidance has to be given for the whenever the child is using the NAM, the cleaning oral hygiene measures with the cleaning of the appliance as well as the area. The proper instructions has to be given. The surgical space support. So work with the surgeons to ensure the oral cavity is free of any bacteria and ensure any oral infections or ulcerations or natal or neonatal teeth are properly treated. Preventive dental care, in such cases, we have to take care of the early childhood caries, where we have to apply the topical fluid application, we have to give a proper dietary counseling, and of course oral hygiene instructions to be given to the parents for their proper involvement. A regular recall visit has to be done for such cases within 3 to 6 months of the period. So growth and development monitoring, how we are going to use this, we have to take the serial cephalograms and also dental cast can be taken and monitor eruption sequence and timing for any ectopic eruptions or delayed eruptions or the missing teeth are there. So we have to check for it. And we have to take care for cross bites or any anterior open bites or any other malocclusions related to cleft lip and palate patients. So next is coming to the surgical support. So we have to manage the human hypoplasia of the malformed teeth. Wherever it is any restorations are required in this area, have to do it. We have to extract any grossly decayed or non-restaurable teeth before doing any bone graft surgery to avoid infection. Next, coming to the orthodontic phase support, we have to coordinate with the orthodontics, where we might require arch expansion, and also we can give the space maintenance wherever it is necessary. So we have to maintain this oral hygiene during their whole orthodontic appliance therapy. Coming to speech and function, identify the early speech difficulties and refer to speech therapists. Also educate the parents about oral exercises to improve this muscular function. Psychological and social support, where we have to build child's confidence through positive dental experiences. Address the teasing or self-image issues by maintaining good oral health and aesthetics. Of course, it needs a lifelong maintenance. So continue preventive care and monitoring to adolescents and also in adulthood, and support the prosthetic rehabilitation if it is necessary in the form of implants or the bridges once the growth is complete. So this is the article which is published in Egyptian Journal of Plastic and Reconstructive Surgery in 2025 by Ahmad Musa and et al., where they have done the surgical and aesthetic outcome in complete cleft lip repair. They have done the comparative study where 44 patients have been diagnosed with complete lip and hospitalized pediatric surgery. They have checked under, they have divided these in NAM group and non-NAM group, and they have concluded that pre-surgical alveolar molding is an effective procedure in improving nasal symmetry in unilateral and as well as bilateral complete palate regarding of nostril width, height, columella, length and angle. Anti-surgical element decreases the alveolar glove, facilitating the primary cleft repair and enhanced tension-free repair. Vermilion volume homogeneity was evaluated in both the group and it was found to be better with the NAM group. Extent of muscle section and surgical difficulty were less in NAM group than the non-NAM group. So these are their findings in this particular study. Another study, which is a systematic review of effectiveness of nasal treatment for babies with non-syndromic complete unilateral cleft lip, has been checked. So this in their design, they have used the randomized control trials and also the control clinical designs. And what they have concluded is there is low certainty of evidence supporting the short-term effectiveness of the nasal wire molding for cleft with the reduction and also with the complete unilateral cleft lip alveolus and the palate. So this is the latest guidelines which is published in American Association of Pediatric Dentistry, where the policy is made for the management of patients' cleft lip and palate or other craniofacial anomalies. You can go through this policy also. And this is the American Cleft Palate Craniofacial Association guidelines, where summary towards for the well-being of the patients is given. So, and these are the questions roughly is asked, like etiology and classification of cleft lip and palate. So these are the contents which I have given here. Then multidisciplinary approach of for the rehabilitation of CSCP. Questions mainly are asked on the pre-surgical nasal wire molding. So you can make your content as per detail. And role of the pediodontist also I have explained. So role of pediodontist in management of cleft lip and palate. In this you can give this particular content and you can use for your questions writing. So I would like to thank you, the Indian Society of Pedodontics and Dentistry, giving me this opportunity to talk on this topic. And I would like to thank the team members who are working for this, Dr. Madhu and the entire team. And thank you very much.
Thank you, madam. Thank you very much. Nice presentation. I think in chat box, there is no questions from students. Any questions
Yes,
from
sir.
exam?
I think so. Few questions like it has got stuck in between. They were asking like that. So I was also having same thing. I don't know. I have recorded properly, but then also at the last time some glitch has occurred. I don't know. So
I think we
have
can give Dr. Seema's email ID or something like that to
yes,
the students so that they can have they can clear their doubts.
Dr. Seema, you stay
Yes,
here
sir.
on this platform for a few minutes and just wait for the questions in the Q&A section.
Yes, sir. Yes, sir.
Just type your answer there only. That will be better.
Yes.
Okay, sir.
Right? Yeah. Thank you. Thank you so much. Thank you.
Dr. Madhu?
We'll go ahead with the next.
Thank you, ma'am. Thanks for the presentation. I request Mr. Dev to display the certificate of appreciation for ma'am.
Seema madam, please accept token
Thank
of
you. Thank you very much, sir.
Very,
And I
very nice
think so-
presentation, Dr. Seema.
Thank you, Dr. Seema.
Thank you. Thank you very much. I will be giving the answers to all of them, whichever are coming in between, sir. Still this station is going on. Thank you very much, sir.
Thank you, madam.
If anyone has any questions, they can put it in the question and answers or in the chat section. Ma'am would just go through it and we'll answer it later. Now I request Dr. Dhanu sir to introduce my dear friend Dr. Amrita for the session Dental Management of children with special healthcare needs. Dr. Dhanu, sir.
Yeah. It's my pleasure to introduce Dr. Amrita Chakraborty. She has done her BDS from MS Ramaya Dental College, MDS from Bapuji Dental College in 2015. She has done MS from University of Southern California, MPH and certification in pediatric dentistry from University of Connecticut. Then I think she's an international speaker now. Diplomat, American Academy of Pediatric Dentistry, Fellow, International Academy of Pediatric Dentistry, pursuing her pediatric dentistry in Gentle Dental, Grand Spas, International Adjunct Faculty at Sharad Pawar Dental College and Hospital, Datta Mega Institute of Higher Education and Research. I welcome Amrita Chakraborty and best of luck.
Thank you, Dhanu sir. Thank you everyone for inviting me for the presentation. I think this is a great opportunity for all the students. I wish I had this opportunity too during my MDS. I hope the students find the presentation helpful, and I will leave my email in the chat box so that anyone can reach out to me if they have any questions. Thank you.
Mr. Dev, you can play the presentation.
My topic for the day is dental management of children with special healthcare needs, and my name is Amrita Chakraborty. This is a little bit about me. I completed my BDS and my MDS from India, and then moved to the United States where I completed my MS in craniofacial biology, DDS. Then I went on to complete my master's in public health, and then my residency in pediatric dentistry. I am presently practicing as a pediatric dentist in private practice in Oregon, and I'm also international adjunct faculty at Sharad Pawar Dental College and Hospital. Let's begin by talking about the definition of special healthcare needs. Special healthcare needs would include any physical, developmental, mental, sensory, behavioral, cognitive, or emotional condition that requires or may require medical management, healthcare intervention, or the use of specialized services or programs. This definition is from ISPPD, and as you can see, the definition itself contains a kind of classification. The condition can be congenital, developmental, or acquired through disease, trauma, or any environmental cause. And they may impose limitations in performing daily self-maintenance activities or in major life activities. In India, over 2.1 million school-age children have disabilities. The classification of special healthcare needs would be under behavioral, cognitive, developmental, congenital, and systemic conditions. For behavioral, some of the examples would be anxiety, ADHD, and autism spectrum disorder, or ASD. Cognitive conditions would be trisomy 21 or Down syndrome, Fragile X syndrome. Developmental disorders, examples would be cerebral palsy or hearing impairment. Congenital conditions like congenital cardiac conditions, and systemic conditions like childhood cancer or cyclic neutropenia. We will not be going in depth into the systemic conditions in this because that will be covered under medical management. So why is it important for us to know about or to learn about children with disabilities? Children with disabilities face multiple barriers to obtaining adequate or even optimal oral health, more so than neurotypical children. Some of these barriers would be financial barriers, language barriers due to any kind of condition that may have, or a simple lack of understanding of language itself of the provider. They may have psychosocial barriers like caregiver beliefs, responsibilities, or higher anxiety of the child, or lower cognitive level. all of which like transportation or any history of discriminatory treatment, school policies not allowing them to take leave from school, or a difficulty locating providers who are comfortable to see these children. There may also be cultural barriers, which would include belief systems about prioritizing oral health. When we talk about management of children with disabilities, we have certain goals that we need to establish. One would be having a dental home at an early age, obtaining thorough medical, dental, and social patient histories, creating an environment that is conducive for these children to receive care, providing comprehensive oral health education and anticipatory guidance to both the children as well as their caregivers, providing preventive and therapeutic services, including behavior guidance and a multidisciplinary approach between providers when needed. Let's go in depth. So when we talk about establishing of a dental home, the dental home needs to be established by age 1. This will help implement individualized preventive oral care. It will help to establish routine dental care, and it also will help in reducing the risk of any kind of preventable disease. Now, treatment begins with accessibility. McDonald and Avery have a great section on accessibility and what are the requirements for accessibility. Remember, it begins from when they call the clinic. It does not begin in the operatory. So keeping these things in mind, there's a list over here will help. Now, let's move on to the first dental visit. Let's begin with scheduling. It is very important for the front desk to remember to ask, does your child have any kind of disability? Do they have other medical providers? Are there any unique needs for accessibility? During the initial exam, we must go in depth into the medical and dental history, try to take radiographs, ideally bite wings, occlusals, and a panel, but probably take the diagnostic. The extra oral exam should consider lymph nodes, TMA, physical disabilities, any signs of abuse. The intraoral exam should include a soft tissue exam, a hard tissue exam, occlusion when possible, because it may not always be possible, and any kinds of oral abuse. We have to take into recording the oral hygiene, which should include the plaque score. It should include any home oral hygiene habits. What are the nutrition habits of the child? During the first visit, also we need to have a history of all the medical providers and send our medical consults as needed. And then we need to treatment plan based on all our findings during the exam. And then the most important part is nutritional and oral hygiene counseling. And finally, obtaining informed consent. Ideally, though, you would be obtaining informed consent also before entries. Now, what are the impressions you get from our first visit? Any physical, medical, behavioral, or intellectual barriers that may exist for ideal oral health. Remember, it is not just the condition of the child, it's also what perspectives the caregiver has and how much they can help the child. Caregiver barriers to support. Do they have enough supports? Are there family members who are helping? Are they in an institution that is open to the idea of helping these children? What are the barriers that these caregivers face? Transportation barriers, any kind of social barriers. We need to make a note of all of that. What are the dental needs of the child? Dental needs includes not just how many cavities they have or if they have gingivitis or any periodontal risk, but it also includes are they able to brush their teeth. Then we come up with what is the prevention plan that is going to be based upon the case risk assessment and the periodontal risk assessment. Then we move on to the treatment plan. Treatment is basically what needs to be done and how can we achieve it. It would include the frequency of cleanings. It will include any modifications to help in improvement of home oral hygiene, any diet and nutrition modifications, any surgical treatment, basically restorations, silver caps, extractions, what is needed. What is our plan for maintenance post-treatment, and what are the accommodations that are needed during treatment itself? From subsequent visits, we need to keep a tab on what we saw or what impressions we had during the first visit and how are we improving it, or how are the child and the caregiver able to improve on those factors. One would be, is there any improvement or decline in acceptance of the environment itself? For caregivers, have they been able to be more involved in the oral hygiene habits of the child? Have the dental needs of the child improved? Are they doing better at brushing? Do they have fewer cavities? Then for the prevention plan, we should periodically reassess during every 3 or 6 month recalls whether there has been a change in the caries risk or whether there has been a change in the periodontal risk. Has their plaque score improved, for example? The frequency of cleaning would be determined by any improvement in plaque score and periodontal risk. For example, initially we may have started off with, okay, let's start with 6 months. And then the plaque score has not improved at the 6 month. Then should we do a 3 month? Or should the 3 month recall that was decided on initially be increased to maybe 3 weeks? Keep in mind, are there any structural barriers to doing this to an increased frequency? An improvement in oral hygiene. Has it been improved? If not, why? Do we have to address any kind of difficulties that the caregivers may be facing or the child may be facing? Are the diet and nutrition modifications that we advised in the first appointment, have they worked? And if not, why? How do we go about creating a more customized diet plan that will help the child? Surgical treatment. After our first visit, we would have attempted some kind of treatment. Was that successful? If not, then how can we ensure future success? Do we need to sedate this child? Do we need to put them under general anesthesia? Can we continue working in the clinic? How has the maintenance post-treatment been? Say you do all your treatment, but if there is still new caries lesions that are developing every 6 months, maybe more aggressive treatment is needed. And then accommodations during treatment. Where the accommodations provided, I'm assuming we say the child has sensory conditions and needed noise cancelling headphones or needed distraction during treatment. Did those accommodations suffice? Have there been any improvement in the child's acceptance of dental treatment? And if not, then how can we further accommodate? So considerations for planning dental treatment. Understanding. We have to be able to understand the cognitive level of the child, their sensitivities, like do they have any sensory sensitivities, any kind of oral aversion, which is very commonly seen in some behavioral conditions, and any triggers for negative behavior. Based on this understanding, we would then develop communication strategies. Do we need to modify how we communicate with this child, or how do we communicate better with the caregivers? Treating active disease before elective treatment. This point, when you're planning dental treatment, may change. For example, do we need to, if this child has come to you with multiple MODOs as well as teeth needing pulp SSCs, do you do the pulp SSCs first, or do you do the smaller restorations first? That would depend on how we feel from the understanding. Would it be better to ease the child into treatment, or would it be best to get the child first in a more stable oral health condition? Remember, during your pulp SSCs, you could be placing silver fluoride on those smaller lesions, which may help the child tide over, taking into consideration any barriers that the caregivers and the child have. That will determine what kind of treatment you're going to plan or how you're going to plan your future treatment. Are there any medical considerations? Do we need to send out med consults? Does the child need any kind of antibiotics before the visit? All of those factors will come into play into planning a dental treatment. Even, can you use nitrous oxide on this child or not? Is it safe? And finally, and the most important, behavior. Behavior will determine what kind of dental treatment we're doing and how. If the child has any kind of intellectual disability, any kind of dental anxiety, any physical disability. So if they have any intellectual disability, our communication strategy will differ. Are they able to cooperate and understand instructions will determine whether we're going to do it in clinic or whether we're going to take the child under general anesthesia. Dental anxiety. Dental anxiety will determine if we phase the child in slowly through easy treatments or do we just jump into it and start working. Physical disabilities. Do we need protective stabilization in the clinic? Any kind of oral aversion, how do we overcome that if there is? If we cannot overcome it, then of course we need to sedate this child. Effectiveness of non-pharmacologic behavior treatment management. I personally always want to try and use non-pharmacologic methods, except for nitrous oxide. I would use nitrous oxide, but can I delay this child going under general anesthesia? Is this child safe to go under general anesthesia? If not, then how do we manage this child in our chair? What is the need for pharmacologic behavior management? Is sedation necessary? Is general anesthesia necessary? All of that will be determined by our understanding of how this child's behavior may be, and also what are the barriers that they have to come into the dental practice and their acceptance of the dental environment. The need for protective stabilization. We're going to go a little deeper into that. Now, protective stabilization is basically indicated for any dental care of children with disabilities who may need help with the extremities. It can also be used for extremely combative or resistant patients, though that use has declined with time. The most important thing for protective stabilization is informed consent. What is the type of stabilization? What is the duration of stabilization? What is the need for stabilization? All of this has to be explained to the caregivers before. You cannot start protective stabilization in the middle of treatment, like you cannot bring in a proposed board right in between treatment. You have to stop treatment, explain the need for it, and then maybe schedule to another day. There are contraindications, like you wouldn't use protective stabilization on a non-sedated patient. You would not use protective stabilization on a patient who may not have emergent dental needs. There are different types of protective stabilization, and McDonald's and Avery has a great section on that. Highly recommend reading it. Now, what are the unique challenges that children with disabilities face, and what would be the solutions? Some of the challenges are, like we already talked about, intellectual disability, physical disability, any systemic conditions, and behavioral disability. The solutions would include communication with caregivers, communication with the patients or the children, and assessing the level of cognition. Never assume that a child with intellectual disability is not able to understand instruction. Maybe the type of instruction needs to change. Modifications to home oral hygiene for physical disability, like using Velcro straps in your toothbrushes or using different kinds of toothbrushes, using toothbrushes that have, the U-shaped brushes. So they're not as effective, but something's better than nothing sometimes. Accessibility in the dental clinic environment. Is your dental clinic accessible? Is the dental chair accessible? Are you able to do treatment? Are they able to read the clinic in an accessible manner? Communication management for visual and hearing disability. We already spoke about how you can introduce different methods of communication like ASL, BSL, or even using computer systems that will help with communication. If a child has a systemic condition, what are the medications they're on? Are there any effects on oral hygiene due to those medications? Are there any urgent medical needs that we need to address through oral health first? Like if a child has to go in for chemotherapy, is there anything urgent we need to do before they can get chemotherapy? Does the child have any emergencies? If so, what can we do about it? Are any diet and nutrition modifications that need to be made for these children, like if they eat puberty, for example? If they have a behavioral disability, we need to talk about if they have anxiety, how do we overcome that anxiety, any dental environment modifications, like, dimming the lights, using noise canceling headphones. are there any routine modifications? For example, just counting down during treatment, any behavioral management for treatment itself. Do we need to use tel schedule? Maybe we need to reduce the amount of tel schedule. We'll go into those in depth in a little bit. Let's start with some of the most commonly asked conditions during your exams. I have kind of used a framework over here that you all can use for regardless of how many marks the question is for. If you have a framework already, whether it's a 3-mark question, a 5-mark question, a 10-mark question, or a 50-mark question, it is easy to put information into that framework. So I highly recommend creating your own framework that you're comfortable with. Autism, you start with the definition of autism, and then what is the cause of autism, then what are the behavioral considerations. Let's go a little deeper into those. Children with autism may have agitation, self-injury, emotional dysregulation. They will have difficulty responding to social cues. Having anxiety in unfamiliar environments, causing behavioral outbursts. They may have oral aversion, very commonly seen in children with autism. They may have limited breathing capacity with anxiety and agitation, like they may not be able to sit still for too long without getting anxious. They seek comfort in repetitive behavior, creating a routine, having the same dental environment, really important. They may be suffering from depression. All of this leads us to the oral health consideration. Because of the conditions, the behavioral conditions that they have, they may have a higher risk of dental caries because it is difficult for them sometimes to brush their teeth, just for example, or to maintain a routine to brush their teeth every day. They may also have a high risk of periodontal disease. All of this is associated with barriers to accessibility of care. For example, because of their behavioral outbursts, because of how they are not comfortable in new environments, they may find it difficult to go to a provider near to them and get regular cleanings. Due to the oral aversion and sleep disorders, they may, like sleep apnea, they have an increased likelihood of oral disorders because they don't brush their teeth. And overcoming that or creating strategies is important. What are our treatment considerations? Consider desensitization visits. Children with autism may be particular about the consistency of the environment, the same room, the same team, the same kind of instruments, having sensory adapted dental environments, reduce your bright lights, reduce noises. Non-verbal children with ASD may have alternate communication methods. So many children with autism may be non-verbal. Extremely important to remember that though a child is not speaking, it does not mean that they cannot communicate. Talk to the caregiver, see when it's available. Consider sedation when it is appropriate, of course. And always include caregiver. Remember, your parents or your caregivers live with these children every day. They may know more about how to deal with behavior than you know. The preventive recommendations would include frequent checkups every 3 to 6 months using fluoride varnishes and dental sealants, dietary guidance to minimize sugary foods and reduce risk of dental caries. They have sensory sensitivities, which precludes them from eating certain kinds of food. So how do we modify that to make it healthier? Modifications of home oral hygiene habits to account for routine, sensory adaptations, and behavioral conditions. So different kinds of toothbrushes, different kind of toothpaste that can be given to them. Next, let's move on to ADHD or attention deficit hyperactivity disorder and ADD. They have difficulty sitting still, they have difficulty following instructions, and they're very easily distracted during dental visits. All of this increases the risk for caries. They also have history of oral trauma, bruxism, and maybe taking medications to manage the condition, which makes their mouth go dry, like SSRIs. So for treatment, we would consider scheduling them with short appointments using tel schedule technique with providing clear, concise instructions because long-winded instructions are very difficult for them to follow. Employ positive reinforcement. Consider breaks during treatment. Consider count, that helps sometimes. Manage short attention span to activities that help the child focus, like using a fidget spinner, counting down, having them even watch TV helps with the distraction and increases cooperation. The prevention recommendations are mostly the same, but especially educating caregivers of helping more by using distraction as a technique to engage them during oral hygiene really helps a lot. Next, we're going to talk about cerebral palsy. Now, I have provided a definition as well as different classification of cerebral palsy, which is really important to keep in your answer. The medical consideration of cerebral palsy would include seizures, possible intellectual disabilities, but that is not always the rule, having sensory impairments, and gastroesophageal reflux, all of which will complicate your final oral health management. What are the behavioral conditions? And the behavioral considerations would also include any physical limitations like involuntary movements. They may have communication barriers due to their intellectual disability or due to them being non-verbal. Remember, don't assume they cannot understand or they cannot communicate. There may be alternate ways of doing it. They may have tactile hypersensitivity, so using the handpiece may be a little tough for them. What are oral health considerations? Children with cerebral palsy often have malocclusion. Is that a priority? We got to decide and talk to the caregiver and come up with a priority for that. They will have bruxism. They will have excessive drooling, leading to perioral dryness. They may have enamel hyperplasia. They also have high caries and high periodontal risk. After mature cerebral palsy, the risk for gingivitis is much higher than the risk for caries because of their excessive drooling. Now that is anecdotal. I'm not sure if that has been proved through studies though. Our treatment considerations would include desensitization visits, both for the child as well as for the caregiver to get comfortable and to know your dental team before. Using mouth props. Like the Mole's mouth prop helps a lot in having the child open their mouth and stay open, because sometimes the kids are not able to do it by themselves. Having shorter appointments tells you to do if possible and if necessary. Having the caregiver around is a sense of comfort for the child and it helps a lot. Using adaptive positioning and using protective stabilization. If your child is G-tube fed, are there any special chlorhexidine tabs that you can prescribe to control plaque? Because most kids with G-tube who are G-tube fed often have plaque in their mouth and calculus. Moving on to intellectual disability. So the behavioral conditions would be a short attention span, restlessness, hyperactivity, and erratic emotional behavior. They do have a higher incidence of caries, gingivitis, clenching, bruxism, pica, and self-injurious behaviors are possible. Not always, but sometimes. This is the classification of intellectual disability through the Stanford-Binet scale and the Wechsler Intelligence Scale. I would highly recommend reading the intellectual disability section in McDonald's. It is really good. Same, consider desensitization visits. Be slow, having the caregiver around. Constant positive reinforcement helps a lot with kids with intellectual disability. Give one instruction at a time. That helps too. Child with intellectual disability who you may not be able to keep put under sedation may need treatment modifications like SDF or Hall crowns. Preventive recommendations remain the same: frequent checkups, fluoride varnishes, dental sealants, and adaptive toothbrushes. Like I mentioned before, create your framework, and that framework will help you put more information into the matter. I highly recommend reading McDonald's and Avery as well as the AAPD reference manuals about these conditions. Transition. Now, our care does not end when the child has reached the age that we're comfortable seeing them at. Children with disabilities are living for longer, growing older, and will need specialized care from general dentists that is beyond the scope of a pediatric dentist. In that case, identifying the timeline of transition for each child, because every child has their own unique needs, providing the patient as well as the caregiver with choices in the matter of transition, creating a team or a community of dental providers who are comfortable seeing these children in your community is extremely important. And also educating caregivers and patients about what to expect from the new office. Always have complete, comprehensive records that you can share with the dental team that you're transferring your child to. These are some of the frequently asked questions. These questions are sometimes asked for 5 marks, they're sometimes asked for 10, 15, even 50 marks. So remember, create your framework. You can use this presentation as kind of like a framework of how to go from definition to classification to barriers, and then go deeper into each condition if you need to. These are my references. I know there's a list of 20, almost like 18 references here, but the most important reference over here is the AAPD reference manual and McDonald's and Avery. If you even like stay within that, you will cover almost 90% of everything that you need to write in your paper. Shameless plug, but genuinely, I do feel that this book will be very useful. I recently wrote a book about how caregivers and pediatric dentists, general dentists can collaborate for improving the care of children with disabilities. This book contains fact sheets for a few conditions, and that fact sheet will help you also kind of create a framework for your answers. It's available on Amazon as an ebook. I've not yet published it, but that's in progress. But for now, it's an ebook. That's the QR code for that. Thank you and good luck with your papers. If you have any questions, I'm here to answer them all. Thank you so much.
A wonderful presentation, madam.
Yes, sir.
Any questions from audience?
Is there questions here, Ravi?
No questions,
I
sir.
think the biggest question is that the screen is frozen from what I saw.
The questions are there. We can.
If any questions, please put it in the chat box or in the question and answer box. Yeah, Dr. Amrita will answer it directly. So moving on, now I request Dr. Deepak sir to welcome Dr. Ashish Saxena for the next presentation. Before that, I request Mr. Dev to display the certificate of appreciation to Dr. Amrita.
Thank you, sir.
Thank you, Dr. Amrita.
Thank you, madam.
Thank you. Bye.
Hello.
Now I request Dr. Deepak sir to introduce the next speaker, Dr. Ashish sir.
Good afternoon, everyone. Once again, it's my privilege to introduce my friend, Dr. Ashish Saxena. He has completed BDS from GDC Indore and MDS from KGMC Lucknow. Now he is working as a professor and head in GDC Indore, and he has total teaching experience 17 years, and he is a researcher and administrator. Area of interest, especially in pediatric and preventive dentistry, children with special healthcare needs, sedation dentistry, aesthetic and cosmetic dentistry, general pediatric dentistry under GA, and dental treatment of medically compromised patients. Over to you, Dr. Ashish Saxena, sir.
Thank you so much, sir. Thank you, Deepak, sir, for introduction.
Thank you.
Admin, please start my presentation.
Mr. Dev, you can proceed to display the presentation.
To the bearers of ISP, respected moderators, PG teachers, and dear PG students. Today is the last session of day 1, and I am going to cover management of children with medically compromised conditions. We have already covered NAM and special healthcare children in previous sessions, and special medically compromised conditions we will cover in this session. Generally, a long question is being asked on this topic, and for a 3-hour question paper, you have to spend almost 40 to 45 minutes to justify your long question. So I will try to justify this topic. You score maximum in this subject. What are the medically compromised children? They are those patients whose health status, as determined by appropriate provider staff in accordance with accepted standards of practice, is likely to change or has changed because of a disease process, injury, disability, or advanced age and underlying disease processes. So we can understand that medically compromised condition means a child will be on some long-term medication, or maybe his health will not be under the parameters which we declare, which we consider as the healthy parameters, and their biomedical reports, their pathological reports, their health status will not be as normal as we expect into a normal range criteria. Almost 1 to 44% children, they are from the general pediatric population who have some kind of medically compromised condition as per the epidemiological studies given by Beers and NS in public health reports. There is a patient classification according to their physical condition, and it has been given by American Society of Anesthesiologists in 2014. The 5 types of criteria are type 1, moderate to mild to moderate systemic illness. Type 3, severe systemic illness limiting patient's activity. Type 2, severe systemic illness threatening to the life. And type 5, morbid patient. To understand the health status of a patient, generally there is a criteria followed, that is Duke's Activity Status Index, and it is scoring from 0 to 58.2. Better the score means the child or the patient is on the healthier side. For the medically compromised patient, he might be having some kind of systemic illness, and these systemic illness may include cardiovascular diseases, respiratory diseases, liver diseases, endocrine disease, renal, neurogenic, sexually transmitted diseases, neurological disorder, congenital chromosomal disorder, metabolic disorder, and maybe a combination of these make a child more susceptible for infection, more susceptible for the diseases. He may be on some kind of immunocompromised drugs also. So before starting treatment or before planning treatment, there is a pre-treatment assessment and evaluation for medically compromised patients, which include initial consultation, medical review, assessment, and collaborative plan. For the initial consultation, which is very important, you have to identify the patient's existing condition, as well as what kind of medication, what kind of previous medical reports are there. Medical review you have to assess the current medication so that what dental treatment you're planning, so and dental medication you're giving to the child, that should not react with previous or ongoing medication. You have to identify the risk assessment because the potential risk of the which may include some kind of bleeding tendency, some kind of complications with the existing conditions, or the dental procedure which you are planning that is going to affect the child overall health, that you have to consider. And a collaborative planning is required where you have to consult, where we have to discuss the patient's present condition with the expert which are giving the child medication, or the child, whatever you are going to give the treatment, that you have to discuss with the expert, the child who is handling his medical condition. We cover hypertension, angina pectoris, cardiac arrhythmias, myocardial infarction, rheumatic heart disease, coronary angioplasty. Child may have some symptoms, maybe some of them, that is chest pain, dyspnea, cyanosis, palpitation, syncope, ankles, cold, pale extremities, clubbing of fingers, and easily. It is basically that can lead to cerebral leakage, myocardial infarction, renal failure, heart failure. Cardiac risks are for non-cardiac surgical procedures likely is less than 5%, and we have to follow nice guidelines for consideration of hypertension, which are given by National Institute for Health and Care experts. This is a protocol which we should follow for any kind of patient, whether he is having cardiovascular disease or renal diseases or disorders. It is a common protocol, and this is important slide so that you can write down these points into any kind of appointment. So as a before appointment, we should give some medication which includes sedatives like Valium 5 to 10 mg, and it is optional one day before. On the day of appointment, you should have early appointments and short appointments. For the day of appointment, you can give benzodiazepines like diazepam or diazolam before of the appointment. During the appointment, you have to make clinical setup like relaxing background music, reassure the patient as well as the parents. Do not plant some kind of big in front of patient. The instruments which are there should be slightly away from the patient side, and the local anesthesia is important. So it has to be completely painless. You can plan or under the isolation or observation optional. Once you finish the appointment, then after the appointment, further assurance the patient as well as to parents, detailed information about the post-operative care, and give analgesics which are going to relieve the patient in a better way. For the management, if the child is having mild moderate hypertension, that is under the limit of 180 for the systemic and 110 for diastolic, dental treatment can be provided for all hypertensive patients except uncontrolled hypertension. You have to monitor blood pressure. Consultation is important, and the same protocol which I mentioned earlier, that to plan the local anesthesia, the amount of adrenaline with the local anesthesia and inject the local anesthesia in a slowly manner so that it is not going to hurt the child, and avoid intravascular injection. So for this, aspiration is a rule strongly. Avoid rapid posture changes that can lead to orthostatic hypotension and syncope. Calcium channel blocks. Do not prescribe erythromycin or clarithromycin. Suppose the hypertension is on the higher side, is more 180. Consultation is primary thing which you have to postpone the appointment till the blood pressure comes under control or comes down. But if the dental procedure is required, hospitalization is important. And with pre-medication, use plain local anesthesia. Avoid NSAIDs except acetaminophen because they can increase the risk of stroke and hypertension. Avoid use of retraction cords, topical hemostatic agents containing epinephrine. This is important point for you all. the amount of local anesthesia without adrenaline and number of volts, how much we can give to the patient. So maximum dose of lignocaine without adrenaline is 4 milligram per kilogram of weight and not exceed maximum 300 milligram. So this is without adrenaline. If you're adding adrenaline, so you can go up to 500 milligram, and that is 7 milligram per kg of the body weight. Amount of local anesthesia which you have in 1.8 ml, it contains 36 milligram of local anesthesia, while 0.09 milligram of the adrenaline in 1.8 ml of your cartridge. Maximum number of cartridges you can give, that is 20 with adrenaline. And for a patient who is on cardiac risk, that you can give maximum number of 4 injection of local anesthesia. Condition second, that is angina pectoris. So it to supply oxygenated blood to heart musculature temporarily. Patient may be suffering from substernal pain that radiates to the shoulder down to fingers and may radiate to mentions. For the management part, advise the patient to eat slightly before the appointment. Pre-medication with short-acting barbiturates is important. Nitroglycerin has to be ready with you. 6 anesthesia plus vasoconstrictor is maximum number of 2 injections you can give in a division of 1:1 lakh of the adrenaline. Your local anesthesia should be slow and session is important. In case of angina, you postpone the appointment and only intensive procedures should be attended. Cardiac arrhythmias, conditions where abnormal pulse rate or rhythm and cardiac pacemaker. Management part, no antibiotic prophylaxis is required. Local anesthesia without adrenaline will increase endogenous adrenaline. So 2 ampule containing 1:1 lakh can be used. You should avoid diathermy, ultrasonic scaling, laser or cautery, because if the patient is having pacemaker, that will be difficult to handle. If INR, that is normal ratio, is 1, INR is within the therapeutic range, and 2 to 3.5, dental treatment can be performed and minor surgery also can be done without stopping the medication, that is anticoagulant drugs. Myocardial infarction, if anginal attacks last for more than 30 minutes, that can lead to myocardial infarction. Patient experience severe substernal pain and may go into shock and cardiac dysfunction. Emergency treatment in case of MI, that is called emergency unit. CPR, if you are expert in that, that has to be essential. You should be trained in CPR. Emergency oxygen is required, nitroglycerin sublingually, and IV thrombolytic agent injection. So in such emergency condition, you should take care of the medical hospital on urgency basis. Management for this, the consultation and device hospitalization, you can postpone your treatment or plan after 6 months. It is generally saying that you should plan after 6 months. Do not withdraw anticoagulants because it may cause the thrombosis, and reduce the dose of oral anticoagulants to maintain prothrombin time level 1.5 to 2 times of the normal level, that is 15 seconds. So keep it up to at least 25 seconds. The present management of MI changed since the 1990s, where elective surgery can be performed maybe after 6 weeks. Follow the stress reduction protocol, which I have mentioned before. Monitor vital signs, use plain local anesthesia. For the local hemostatic measures, constant pressure is required, gel foam in the socket after extraction. Multiple sutures should be given, and heavy bite pressure for at least 1 hour. Naproxen is the drug of choice in case of pain. Rheumatic heart disease, the disease of altered immunological reaction to group A beta hemolytic streptococcal infection. The most affected valves are mitral valve and aortic valve subsequently. The features which include septicemia, petechial hemorrhages, finger clubbing, embolic complications in kidney, brain, eyes. For the treatment part, prophylactic antibiotic therapy is very, very important. For all procedures, you should go for the prophylactic antibiotic therapy, where the manipulation of gingival tissues, where peripheral regions or perforation of the oral mucosa is there. Where we should not prescribe antibiotics, they are routine anesthetic injections through the non-infected area, taking dental radiograph, placement of RPD, placement of the orthodontic appliances, shedding of deciduous teeth, and bleeding from trauma to the lips and oral mucosa. These are the conditions where you should not give antibiotic prophylaxis. Otherwise, any condition where you're handling oral mucosa, gingival tissues, or periodontium, there you should prescribe antibiotic therapy. What type of treatment can cause bacteremia? So there is a list in which you can see extractions, multiple extractions may cause bacteremia on a higher level. Periodontal surgeries, they can cause, and the scaling and root planing, they can cause bacteremia. Other treatments are also there which can cause at a lower range, but these three treatments may cause bacteremia on a higher level. For the management, history is important, consultation is important. Manage the anticoagulant therapy. Antibiotic coverage is important if the patient is already on penicillin. So, before, likely therefore, clindamycin, cleft should be selected for prophylaxis. Other approach, wait for at least 10 days after completion of antibiotic therapy. In this instance, the normal regimen can be used. Prescribe antiseptic mouthwash, local anesthesia with vasoconstrictor to minimize the bacteremia, and do the treatment as less traumatic as possible. And if you have to plan for 2 or 3 appointments, try to keep the appointment interval of 2 weeks. This is a list for the antibiotic prophylaxis, which is suggested by American Academy of Pediatric Dentistry, where you can prescribe if the child is able to take oral drugs. So you have to give 50 milligram per kilogram of the body weight amoxicillin. If child is not able to take oral medication, in that case, you can prescribe ampicillin or cephalosporins, 50 milligram per kg body weight, that is intramuscular or IV route. If child is allergic to penicillin or ampicillin, in that case, you can prescribe azithromycin, clarithromycin, or doxycycline. And in case of allergic to penicillin, the IV route or IM route patient can be given cefazolin or ceftriaxone 50 milligram per kilogram of the body weight. For respiratory diseases, we will consider bronchial asthma, COPD, tuberculosis, where patient will have symptoms like cough, wheezing, cyanosis, finger clubbing. In bronchial asthma, the etiology may be allergy, viral infection, or the familial. For management part, consultation with the expert who is handling child's reduction protocol. That means early appointments or short appointments, and any drug which is required to make child keep and calm. Prophylaxis for irritable pregnancy, that means steroid, double dose of that steroid, antibiotic coverage should be there. Post-operative bronchodilators, that means theophylline, should be prescribed if child is already using. And in your clinic also, you should keep theophylline bronchodilators. Oxygen supply should be ready. Patient on bronchodilators to avoid prescribing macrolides like clindamycin, azithromycin, ciprofloxacin, and avoid aspirin, NSAIDs, barbiturates, narcotics, sulfide-containing preservative anesthetics. They may precipitate asthmatic attack. Therefore, plain local anesthesia is recommended for severe asthmatic patients. In case of asthma attack, aminophylline 250 milligram IV can be given. Hydrocortisone 100 milligram IV very slowly can be given. Oxygen can be given. Plus, you can ask for a patient for the hospitalization. For chronic obstructive pulmonary diseases, irreversible air obstruction occurs either non-bronchitis with bronchitis or emphysema. Etiology may be smoking or the environmental pollutants. For management, just like the previous asthma consultation, schedule appointments to allow respiratory in the afternoon. Semi-supine or upright chair position may be better for treatment. Avoid pre-medication with narcotics or barbiturates as they are respiratory depressants. Keep bronchodilator inhaler accessible. Avoid macrolides, ciprofloxacin, same as I have mentioned in the asthma. Avoid bilateral palatal or mandibular nerve blocks to avoid the sensation of respiratory obstruction. Use of rubber dam is not advised important factor which you should remember. And avoid antihistamines and atropine as they lead to dry mouth and increase mucus production. For the dental management of a patient who is suffering from tuberculosis, elective dental treatment should be deferred until the patient has been declared non-infectious by a physician. Use an airborne infection isolation room to provide urgent dental treatment. Drugs, INH and rifampicin can lower platelet count and increase the risk of bleeding. Avoid acetaminophen if serum amino transferase is elevated in patients taking INH to avoid the hepatotoxicity. These are the cylinders which we use for supply of oxygen to the patient in case of need. And this bag valve mask should be used to deliver positive pressure to a non-breathing patient. This kind of your type suction tip, they are available for non-damaging areas so that tissues will be in a safer condition. Liver disease, cirrhosis and hepatitis. We all know what are the functions of the liver. Still, exocrine function by production of bile salts, CBH and lipid metabolism, detoxification properties, production of bilirubin from breakdown of hemoglobin, production of albumin, clotting factors, plasma, protein, urea, amino acids. So you can understand it is a very, very important organ for the body. Patient will have some investigation reports where the hepatic functions are not normal. He may be having serum bilirubin, which if elevated, intrahepatic or obstructive liver diseases, serum ALP, if elevated, obstructive liver disease, albumin must be decreased, prothrombin time elevated in liver diseases, and antigen antibody markers to differentiate different types of hepatitis. Liver cirrhosis, hepatic parenchymal damage with fibrosis and damage to the normal lobular pattern of liver. Etiology may be alcoholism, hepatitis, liver autoimmune disease, hepatotoxins, and generally these signs will be present: jaundice, bleeding tendency, portal hypertension, ascites, hypoglycemia, hepatosplenomegaly. For both the cases, whether it is cirrhosis or any kind of liver disorder, management will be medical consultation, liver function test which are required, correlation screening profile, regulation of the bleeding tendency, blood transfusion history prior to surgery if required, and vitamin K injection 10 milligram 1 hour before and after the surgery. Stress reduction protocol should be followed. No prophylaxis antibiotics if required. NSAIDs including acetaminophen as well as codeine, meperidine should be avoided. Avoid use of metronidazole and vancomycin. High infection control measures should be followed where there is a liver diseases present. These drugs should be avoided, which are hepatotoxic, tetracycline, erythromycin, and minimize the use of drugs which are metabolized into the liver. Avoid amide local anesthetics also. LA can be given in a small doses and least concentrations. Avoid any major surgery if it is required, so least amount of surgical intervention, and hemostatic measures should be followed. These are the drugs, analgesics, antibiotics, and anesthesia, which we can avoid and which we can prefer in liver disease. So what are the preferred drugs? Analgesics, you can go for paracetamol and tramadol. Antibiotics, clindamycin, ceftriaxone, or meropenem, you can give. While for the anesthesia, Easter type of anesthesia, you can give, that is procaine and chlorprocaine. Amide types of anesthesia should be avoided. Amide where the name of the local anesthesia comes twice, or I comes before the cane amide anesthesia. For endocrine diseases, we will consider diabetes mellitus, hyperthyroidism, adrenal insufficiency. Diabetes mellitus, it is a chronic complex disease with metabolic and vascular components. In this disorder, the metabolism of insulin, CBH, protein, and fat leads to elevation of blood sugar level. Vascular components, atherosclerosis, microangiopathy of small vessels. So these patients are susceptible for the infection. And this may lead to because of hyperglycemia, vascular insufficiency, ketoacidosis, and neuropathy. For the management part of the diabetic patient, consultation and controlled cases should be referred to physician and only emergency treatment should be performed. Stress reduction protocol means any kind of sedatives is required, early appointment, short appointments, plan for a well-ventilated area, and any instruments which can create stress, it should be far from the side of the patient. Music should be good into the clinical area, well informed to the patient as well as parents, and do not create any sudden changes into the working area, no surprises. These are the stress reduction which should be followed. Non-insulin controlled patient, all dental procedures should be could be performed. Prophylactic antibiotic administration the day before and 2 days after surgery is generally followed. Avoid aspirin or any other NSAIDs in patients using sulfonylureas because they can worsen hypoglycemia. For another endocrine condition, that is hyperthyroidism, it is increased secretion of thyroid hormones T3 and T4 into the circulation that can lead to thyroid crisis. Patient may have signs and symptoms as increased appetite, loss of weight, warm, moist skin, irritability and nervousness, fine tremors, muscle weakness, increased cardiac output, pulse rate and blood pressure, tachycardia, dyspnea on exertion, and exophthalmos. For the management of thyroid crisis, consultation is important. You should postpone the surgery until thyroid dysfunction is under control. Stress reduction protocol, avoid the use of vasoconstrictor in local anesthesia. Aspirin and NSAIDs increase the amount of circulating T4, so use appropriately. Ciprofloxacin shouldn't be taken with levothyroxine because this antibiotic decreases the absorption of thyroid hormone. Avoid atropine as they may lead to thyroid crisis because it differs the normal heat control mechanism and can cause tachycardia. So, symptom-wise, when you can notice the thyroid crisis, early symptoms are restlessness, nausea, abdominal cramps. Late symptoms are high fever, tachycardia, high pulse rate with severe hypotension, and tachypnea due to pulmonary edema. How to manage the thyroid crisis? You have to take a medical aid, so urgent call, cold packs to decrease the temperature, oxygen supply, CPR if you are expert in that, 100 to 300 milligram hydrocortisone IV, and IV fluid as a supporting measure. If the thyroid level is low, that means hypothyroidism. So untreated patient with severe hypothyroidism exposed to stressful situations like trauma, surgery, or infection can develop hypothyroid. The management part, you have to go for medical help, cover the patient to conserve body heat, administer hydrocortisone, and provide CPR if required. In case of adrenal insufficiency, the primary adrenal suppression, that means Addison's disease, or secondary adrenal suppression, pituitary or hypothalamic disease, prolonged corticosteroid therapy will be there. Adrenal suppression should be suspected if the patient is taking to follow the rule of 2, that means 20 milligram or more of cortisone daily, 2 weeks or more for the episode, and if the patient is having any episode within a period of 2 years. For management, you have to consider patient who has taken corticosteroids in the last 2 years, patient who are under corticosteroid therapy, and there is an emergency. So first you will take patient who has taken corticosteroid in the last 2 years, reinstitute the previous dose of corticosteroid 2 days before the day, and continue the steroid therapy for 1 week post-operatively. If patient who is under the running corticosteroid therapy, so double or triple the dose day before surgery and day of surgery. After the 2 days, reinstitute normal dose after that. For emergency patients, 125 milligram of hydrocortisone is given IV at the time of surgery, and normal dose is doubled for 2 days following it. Treatment-wise, follow the stress reduction protocol, and if the patient is planned under GA, so under GA, intramuscular 100 milligram of hydrocortisone 1 night before, repeat the dose immediately before operation. Sometimes anesthetists give IV drip, cortisone during operation time, and after the operation, after the working, 50 milligram hydrocortisone after recovery. 1.5 to 2 times dose and dose third day. So during the it can be given by IV, but after the surgery, hydrocortisone 50 milligram after recovery, second 2 times, and third day dose. This is what is the case of patient. Adrenal crisis, you have to manage through position of the patient in shock position. Here you can see into the picture, and oxygen supply, administration of glucocorticoids, that is IV hydrocortisone 100 milligram followed by 100 to 200 milligram hydrocortisone in 5% dose by continuous IV infusion. Fluid and electrolyte replacement, apply cool, wet or ice packs, and hospitalization is required. Renal diseases, we will cover renal failure, kidney transplantation. Patient may have clinical signs as nausea, vomiting, loss of weight, pillow, anemia, hypertension, congestive heart failure, pulmonary edema, elevated serum creatinine, and elevated blood urea nitrogen. For the management part, if the patient is on hemodialysis, consultation is important. Same protocol which have been mentioned. Avoid drugs that are excreted to the kidneys. While we were treating the patient who are suffering from liver disease, we should avoid the medication which are passed out through the liver, and same criteria we should follow when patient is having some kind of kidney disorder. So those drugs which are excreted through the kidney, they should be avoided. The nephrotoxic drugs like cefpine, NSAIDs, acyclovir, aminoglycosides, metformin, glibenclamide should be avoided. You can postpone the work or the treatment till the same day or better day after the dialysis. Least traumatic surgery should be there. Least amount of local anesthesia should be used. You can advise antibiotic therapy to avoid subacute bacterial endocarditis, and hive infection control measures. The patient underwent renal transplantation, medical consultation, then stress reduction protocol, regulation of corticosteroids with the consultation of a physician, avoid nephrotoxic drugs, prophylactic antibiotics to minimize bacteremia, and avoid the cytotoxic drugs. High infection control measures should be followed. Like I have told earlier, here we have to know the drugs which can be avoided and which are preferable. So in case of analgesics, you have to avoid aspirin and NSAIDs. For the antibiotics, you have to avoid cephalosporins and tetracyclines augmented. Anesthesia, Procaine. So what we can prefer in case of anesthesia, we can prefer amide anesthesia. That means lignocaine or similar kind of anesthesias. Analgesics, we can give fentanyl, tramadol, or paracetamol. While antibiotics, we can prefer azithromycin, clindamycin, metronidazole, erythromycin. Neurogenic diseases like epilepsy. Neurogenic disorder is the disorder of the brain. This is the most common kind of neurogenic disorder. So for the management, consultation with the physician or the expert, postpone surgery until seizures are well documented. Anticonvulsant pre-medication should be taken into consideration. Stress reduction protocol, avoid hypoglycemia and avoid lengthy procedures. Suppose if there is a seizure, so in that case, you have to stop the procedure. You remove all the instruments away from the patient, put the patient in supine position near to the floor. If dental treatment has begun, try and ease the patient onto that side of the chair and avoid aspiration. Do not put anything because there is a clenching position. Place a bite block or tongue blade between teeth so that will not bite the tongue. Generally, within a period of 5 to 10 minutes, seizure will go off. If it is still continue, in that case, you have to take the medical help. HIV, acquired immunodeficiency syndrome, is a condition with generalized liver opportunistic infections, malignancies, progressive periodontal diseases, leukoplakia, xerostomia. These all conditions will be there, and it is transmitted via blood, semen, vaginal fluid, or breast. For the management of AIDS, consultation is important. Topical antifungal agents, they include nystatin, ketoconazole, clotrimazole, iconazole, and Daracin. Antiviral therapy is recommended. Oral acyclovir is most frequently used. For the management of leukemia, these are different drugs which comes into the form of sprays, gels, and lozenges, which can be prescribed. There are no contraindications related to the use of local anesthetics in patients with HIV/AIDS. Antibiotic prophylaxis is recommended for severely neurogenic patients, and PE is required to reduce risk of transmission after occupational exposures. Blood diseases like anemia, leukemia, or hemophilia. So, in case of anemia, management will include reports, complete blood picture, the medical person. Post the hemoglobin concentration is less than 10 gram. Consider iron and multivitamin therapy post-operative to increase the hemoglobin level, and local hemostatic measures and prophylactic antibiotic therapy to prevent post-operative infection should be avoided. For leukemia, progressive overproduction of immature WBC in the blood, decrease level of RBC and platelets. Same management, consultation, and the complete blood picture. Hospitalization is required. Dental treatment should be performed before starting the chemoradiotherapy. Patient in long-term remission can undergo dental treatment, while patient with advanced or relapsed disease with reserved prognosis should receive palliative treatment. Local hemostatic measures and prophylactic antibiotic therapy to prevent post-operative infection should be provided. Prophylactic rinse of chlorhexidine is also useful. For hemophilia management, lab investigations are required, consultation and hospitalization is required. Replacement of the deficient factor, which is there as per the reports, and platelet replacement and major surgical procedures. Utilize a traumatic surgical protocol as possible. Local hemostatic measures can be followed, and no NSAIDs should be prescribed. Paracetamol can be considered. For cancer patients can suffer oral toxic effects secondary to anti-neoplastic in the form of therapy or chemotherapy. Based on reviewed literature, elective dental treatment can be provided before chemotherapy, with emphasis on the elimination of infectious foci. During chemotherapy, dental treatment should be limited to procedure and can be done after chemotherapy, with a special consideration the patients receiving IV biphosphonates. Dental surgeon should be alert to the possibility of neutropenic sepsis in any patient with a dental infection who is currently receiving chemotherapy or received chemotherapy in the previous 6 months or had a stem cell or bone marrow transplantation in the last 6 months. Who don't have neutropenic sepsis, dental infections may be treated in primary care, but must get advice from patient's oncologist or hematologist team. Some of the emergency drugs which are very important to know if we are going to handle medically compromised patients. So these are the important drugs. First one is epinephrine. Use of epinephrine is second most important drug after oxygen in the emergency armamentarium. It is supplied in 1,000 ampule as given to the picture, and some side effects are there. Side effects of epinephrine include hypertension, tachycardia, cardiac arrhythmias, chest pain, anxiety, and headache. These are the drugs you should consider: albuterol, nitroglycerin. The use of albuterol is for acute asthmatic attack, and there is a and generally it is a kind of inhaler which can be given. 2 puffs are required to give to the patient. The side effects are tachycardia and the anxiety. While the other drug is nitroglycerin, and it is used for the treatment of chest pain, angina pectoris, myocardial infarction. Its action is vasodilator, and it has to be given sublingually. It is like one spray, 0.4 milligram every 5 minutes. Other drugs are aspirin and diphenhydramine. Aspirin, it is for the treatment of suspected MI, and it is supplied as chewable tablets. Side effects is dyspepsia. Diphenhydramine, it is used for the allergic reactions of slow onset and it is given as an adjunct to epinephrine in severe allergic reactions. Generally, it is supplied 50 milligram in one vial, and side effects are sedation and the dry mouth. Other drugs are midazolam. Midazolam is used 1 milligram per ml or 5 milligram per ml in 10 ml. It is used for anticonvulsant for management of status epilepticus or seizures from local anesthetic overdose. Side effects are sedation or the depression. Other drugs which we can use, they are corticosteroids like benzodiazepines, opioid is to be used, and respiratory stimulants can be used for the treatment purpose. We should have a basic idea of local hemostatic agents also. These are the different kinds of local hemostatic agents: gel foam, bleedex, surgical, Tisil, Apostat, cyclocapron, and Amic. So these agents can also be kept into your armamentarium where the emergency drugs are there. For the management of the medically compromised patient, it is important to know that management is basically dependent on 2 or 3 things. That is always starts from the medical consultation, having the basic idea of the disease, planning of the treatment, and consideration of the diagnosis and prognosis, which is going to affect with the medication of the child which is already in a running condition. These are important key points which you should remember for the management of the medically compromised patients. I would like to conclude with this. Dentists are not just treating the teeth in patients, but the patients with teeth. So any systemic condition the patient having will influence the nature of treatment. An adequate thorough medical history should be included in history taking, and the management of such conditions should be known by any dentist who is treating those patients, so that we can avoid unfortunate incidents from happening. These are the questions which are generally asked. So you can understand, basically they are asking management part, which with any kind of disease. If child is having some kind of cardiovascular disease, if child is having some kind of respiratory disease, endocrine disorder, HIV, child suffering from renal diseases, or child is suffering from bleeding disorders. So mainly they are focusing onto the management part. If we are describing too much onto the disease part, like for a cardiovascular disease, we are describing cyanotic part and a cyanotic part which is not required. If we are describing renal disorder in a lengthy way and which is not required. So you have to just give a brief idea of the disease, and you have to main focus onto the management part. I would like to advise all the PG students to go through this blog. It is nicely given by Dr. Seema Bargale, which is available onto the ISPPD website. Its link is also here. It is given to prepare yourself for theory as well as for clinical examination, where theory part and all the exercises of the clinical part, including pedagogy and Viva also. So you have to read once. It will give you a nice idea about your profession, which will give you to make your timetable in a better way, to plan your all subjects, to plan your all topics, and this will be very, very useful for you all. The same topic, medically compromised patient management, has been covered by Dr. Shalini Garg and Dr. Daya Srinivasan, and their e-lectures are also available onto the ISPPD website. They have covered slightly detailed into the cardiovascular or respiratory or any systemic diseases. And here in this presentation, I have covered more onto the management part. So once you go through both the lectures and this lectures, you will have a complete idea about the management of medically compromised children. Here are my details if you want to have, and for any kind of questions, for any kind of query, I am always available. So thank you very much. I am really thankful to the ISPPD for giving me this opportunity. I am thankful to Dr. Madhu K, Professor and Head for KLE Department of Pedodontics, and ISPPD office bearers, and you all definitely who are listening to me. Thank you very much.
Thank you very much, Doctor. It's a wonderful presentation by Dr. Ashish Saxena, sir. Dr. Madhu,
Thank you so much, sir.
Dr. Ashish, fantastic presentation as usual. So let's see any questions are there in chat box. Ravi?
No, sir.
Some questions.
Sir has answered all the questions on the question and answer section. If
Some
any
questions.
questions, you can just mention it in the question and answer section. Sir is answering it live. Any further questions can be made to sir's email ID. Sir will definitely reply back. Thank you, Ashish sir. That was a wonderful presentation. I request Mr. Dev to display the certificate of appreciation to Dr. Ashish Saxena.
Thank you so much, sir. Kind regards, sir.
Thanks a lot, Ashish.
Thank you.
I thank Dr. Deepak sir and Dr. Dhanu sir for
Thank you very
moderating
much, sir.
the afternoon session. I request Mr. Dev to display the certificate of appreciation for Dr. Deepak sir and Dr. Dhanu sir. Thank you, sir.
Thank you, sir. Thank you very much.
Shall we end the session, sir?
Yeah.
Yeah.
Just
Thank you,
waiting
sir.
for the certificates to be displayed. Yeah. Dhanu sir.
Dhanu, sir.
Thank you so much, sir. Dhanu, sir. I have two superstars, Dhanu, sir, Deepak Bhayya, sir. Huh?
Dr. Madhu, I think we can close the session now.
Yes, sir.
Yes, sir. One more certificate, I think, is
Okay.
displayed,
Okay.
sir. After that, we'll just end the session, sir.
Yeah.
And we'll start tomorrow by 8:45. We'll start.
And I have told Dev to take care of the video part, that he should check the videos, like
Yes, sir.
everything is done.
Yes, sir. Yes.
Clear? And
Yes.
anyway, we will be uploading all the videos on website. That's okay.
Okay, sir.
Yeah.
Tomorrow we'll start by around 9:15, sir.
Yeah,
Thank
yeah,
you.
exactly 9:15. Yes, I will be there.
Yes, yes. Thank you, Dr. Deepak.
Thank you, sir. Thank you very much.
Thanks a lot.
Thanks a lot, sir.
Thank you, everyone. Thank you, sir.
Thank you, everyone.
Thank you,
That's all
everyone.
for today. We will be starting the tomorrow's session at 9:30 a.m. sharp. I request
9:15.
everyone to join at around 9:15 itself. If there are
Yes.
any glitches, please make note. The presentations will be uploaded on the ISPPD website after all the sessions. Thank you, everyone.
Thank you, sir.
See you all tomorrow. Thank you.